really provides us with one of the best types of evidence that we can use to help determine how we can address some of these conditions. So the LIFE project is really intended to be one of the biggest projects that we have um, undertaken in Jamaica. It's island-wide, and we'll be going back to communities that were part of the last Jamaica Health and Lifestyle Survey. And that's where the data you saw me presenting earlier came from. We're going to go back into these communities and look for persons who had participated maybe 5-6 years ago in that study. And we'll be doing this by going house to house. But in addition to that, we're going to be looking for other persons who are living in these areas to participate in the study. And that's how we're going to get our cohort study together. The study has a number of parts. One part, of course, is a questionnaire where we'll be asking a lot of questions about risk factors for non-communicable diseases. So that would be things like your cancer, your heart disease, which includes stroke and diabetes. And we know that there are several factors that increase your risk of these things: your family history, your lifestyle factors, what you eat. These are all important factors that increase your risk. And we'll be asking about these. We'll also be asking you to give samples, blood samples, urine, hair, and nails. We haven't been doing much saliva because of the pandemic, but these samples will also help us to understand how your makeup and other things that are happening in your body can increase your risk of these conditions. And of course, once we have these kinds of informations and we follow people over time to see what happens to them in terms of their health, it will help us to understand what is really driving a lot of the pattern of disease that we're seeing, not just in Jamaica, but in the Caribbean and among other Black populations as a whole. So what are the benefits from being part of this study? Well, in some cases, it can help you to understand your health. So Nurse is online and she has found many persons just looking through the reports who had diabetes and didn't know they had it, or whose blood pressures were high and they didn't know that they had high blood pressure, or whose blood pressure or their diabetes was not well controlled. People have been anemic. These are things that you'll find out just from participating in the study. It will also help us on a national level to understand what is causing us to have all of these chronic diseases. And from the samples that you're providing, we may be able to pick up new tests and ways of picking up new different forms of cancer. So today we're talking about prostate cancer, but even picking up people who may be at risk for developing diabetes or heart disease. And this information will help us to identify ways that we can prevent a lot of the burden that we're seeing now from these conditions. So we're part of a team. We're working not just from the University of the West Indies Caribbean Institute for Health Research, but we're also working with investigators from Fox Chase Cancer Center and the African Caribbean Cancer Consortium. Dr. Camille Reagan is a Jamaican. She's based in Philadelphia, and she's one of the principal investigators, as well as Dr. Ashing, who's a psychologist who does a lot of work with cancer survivors at City of Hope Cancer Center in Los Angeles. And a number of other investigators from the Institute are listed here. Many of them have different disciplines, so psychology, internal medicine, genetics, statistics, and all of these are important in helping us to come together to understand the information that we're collecting from you. And many of you will have seen some of these persons in the field. These are our lead research assistants, and tonight we have Mr. Janelle Williams leading out on tonight under discussion. So we always end with our picture of the tree. This is the famous baobab tree from Africa, which is one of the symbols that we use for the life. And it's really one of these trees that survives even when things are tough, because it has roots that go down deep, and it provides a lot of shelter to animals and other people, even in times of difficulty and famine. So thanks again for joining us this evening, and we hope that you will continue to engage with us. And feel free to ask us any questions you have about what we're doing the study, what we have found to date. And these are things that really are intended for you to benefit from. And so we want to keep making sure that we're fulfilling that mandate. So with that, I'm going to stop sharing screen and I'll hand over to our moderator.
All right, thanks, Prof. Marshall. Very comprehensive background on the project that we're doing. And of course, one of the outcomes that we're looking at, and so we are actually focusing on not just cardiovascular, but also cancers. prostate cancer being one of the most dangerous cancers in Jamaica right now with a high mortality rate. So very relevant. Thanks, Prof. Marshall. So right now we are going to go into a little bit of discussion around prostate cancer. And for that discussion, we have Dr. Roberts online. So just a little bit of background about Dr. Roberts. So, and Dr. Roberts, you can always jump in and correct. But Dr. Roberts is a consultant urologist. He obtained his medical degree at the University of the West Indies, where he completed a fellowship in urology in renal transplant at the Dalhousie University in Canada. Now, he returned to Barbados in 1987, where he had, it's 1987.
No, returned to Bahamas.
Bahamas, yes. Where pioneering services were conducted in urology in both the private and the public sector. Now, Dr. Robert, he has an MBA in Healthcare Administration and Policy from the University of Miami, and is also a graduate of the UWI Caribbean Leadership Institute. So he is the immediate past director and senior lecturer of the UWI School of Clinical Medicine and Research in the Bahamas, and is actively championed the cause for universal health coverage as the first chairman of the board of the National Health Insurance Authority. In 2017, he was awarded the Lifetime Achievement Award by the Caribbean Urology Association, and was also the recipient of the Order of the British Empire on Queen Elizabeth II New Year's Honors List. Prostate cancer is one of his primary research interests. So right now, we are seeing that we have a very, very experienced person online who can lead this discussion around prostate cancer. So Dr. Roberts, I know you've been in this field for quite some time. So let's just start off the discussion by you telling us and everyone who is online, what exactly is prostate cancer?
Well, the way I like, when I talk about prostate cancer, the way I like to do it is that what we are trying to do is we are trying to engage men. Mm-hmm. And as you know, universally, especially Caribbean men, it is our nature not to be concerned about our health, because it isn't macho to be talking about a sick man. You know, real men don't have pain, and real men don't visit the doctor. So we have poor health-seeking habits. And so when you talk about, introduce a topic like prostate cancer or any disease, you've got to find a way now, how do I engage men? Because they don't want to listen. You talk about prostate, how do you engage men? And so the way I like to do it, I just want to, can I screen share for a minute? I just want to give you an overview of what I like, how I like to look at prostate cancer.
Sure. You can go ahead.
And I hope to direct your questions a bit. So I just want to bring up one slide here. Okay, can you see that slide?
Yes, we're able to see it, Dr.
Yeah, okay, good. I like to call this the Roberts 10 Main Concerns of Prostate Cancer. And so when I get in, when you start to talk to men about diseases, they really not interested. So I try to say, what do I think if I was a man being a typical Caribbean man? I would say the first thing you want to know is, listen, can I get this condition? Mm-hmm. If I can't get it condition, I don't want to hear about it. Now, if you say I can get it, then I want to know, can I die from it? And if I can die from it, then you can attract my attention. And I can say, okay, tell me what it's about, since I can get it and I might die from it. Maybe it's something I need to know. And then they would say, so why do we get this? And then they say, whoa, how do I know if I have it then, since I can get it? And then can you do something about it? Can you treat it? And then, okay, so you say, okay, well, so what can I do then? Okay, and then finally you want to know and say, well, okay, I've gotten their interest now, and they say, right, so anything else I need to know? And can I get someone to help me to do this? And at the end of the day, when you talk all about this thing, what's the best I can hope for? Mm-hmm. Yes, in the way if I get it or something. So I'm trying to direct the conversation like that. So I'm going to answer your question now, going back to where you say. You ask me, so what is this all about?
Yes.
And I'm going to say that you really want to know what it's all about because you can get it. And in our country, and I'm sure it's no different because we come from the same stock. We both have African ancestry. And the average, and no matter where you are in the world, prostate cancer is the most common cancer in men. The only one that is a little higher would be in countries where they smoke a lot, and so lung cancer might be in charge. But after lung cancer, it's prostate cancer. In our country, we don't smoke much. So in our country, every week, on average, and we have a population of about 350,000 people. And our records show that every week in this country, we can diagnose at least 2 men with prostate cancer. Wow. And every 2 weeks in our country, at least 1 man is buried because of prostate cancer. And I can tell you, and the women are on this program because, and if the men want, they'll tell you, as you said in the beginning, someone in my family, my mother, my brother, my father, my uncle, or someone I know, my neighbor, everyone knows someone who had this terrible disease. And more importantly, especially in the Caribbean, which we can talk about later on, is the fact that when we do come with prostate cancer, when we detect it for the first time in our countries, on average, about 8 out of the 10 men who come for the first time, the disease has already advanced throughout the body. It's not early. In fact, the evidence shows that in the Caribbean in particular, we are #1 in terms of men dying from prostate cancer in the entire world. Okay? And the worst part, the evidence also shows that those men that do come, when they come for the first time, that 70% of them present with advanced disease. So in other words, the cancer, there's evidence, clear evidence that the cancer has spread outside. So I say to the men, if I get their attention, then they're going to say, yeah, okay, this sounds like it's something I know. Tell them sitting around, count. And you will find, count 1, 2, 3, 4, 5, 6. If you were sitting in the 6th chair, you are next.
So Dr. Roberts, tell us though, because from what you've said so far, you're seeing that it's quite prevalent. Why are we not seeing more men going into the doctor's office and getting tested, doing some form of, yes, we know that we have, men in general have poor health-seeking behavior, but why is it that, outside of that, why is it that we can't get our men to go and get tested before it reaches such an advanced stage? What do you?
Good, and I just want to screen share a little diagram I'm going to show you now, and I want to show you why that is so. Now I want you to imagine, the thing about urology is a lot of the things that we do is hidden inside the body. Can't see it on the outside. So I like to draw these little diagrams, and this is a favorite slide that I show. I want you to imagine that this is a man that's cut in half and you can see the inside. And here is his bladder. And then, of course, you realize he empties his bladder, he pees out through into the penis. Here's the testicle that makes the eggs or the sperms, and they swim up this tube and they find their way out in through the penis. Now, when a man has sex and he ejaculates, or as we say, he comes and all the white fluid comes out, I described that white fluid is what keeps the sperms alive. It gives it energy, it gives it direction, it protects it. But that white fluid is not made by the testicle. It's made by this at the bottom of the bladder called the prostate gland. And so what happens is that when the sperms make the eggs and they swim up this tube, then the prostate makes the white fluid, mix everything up, and out it comes. So the prostate gland right here is where we attract it at the bottom of the bladder. And it's deep inside, so you can't feel it from the front. The only way you can feel the prostate is you have to put your finger in the back. And that's what the men don't like.
That's what they don't like.
So the first thing I'm going to say to you is that you've got to understand what the prostate is, what it does, and why it is such a phobia, why the men hate it. Because, you know, in our society, only one thing's supposed to happen in the back passage. Something's supposed to come out. Nothing's supposed to go in. Okay? So now...
So the question is, how do you alleviate that fear?
Now, well, that's why we're having this program.
Yes.
We want to talk about awareness, and I'll come and I'll tell you later on. I strongly believe that once you can get these men attention and they realize what's going on and you show them their options, I firmly believe, and we have evidence to show, that they can change their behavior and they can have very positive health-seeking behaviors. And so now, once we focus on this prostate, I like to say that there are a couple of things that you need to know about the prostate. So you got to interest men in their prostate. They're trying to figure, you know, this prostate, this thing is hidden. Well, you know, yeah, it does something. What's so fascinating about it? Well, the one thing that's fascinating about the prostate is that it is, as we get older, everything, once we reach around 40 to 50, we slowly start to die. The body changes. Everything starts to go away. Our hair gets gray, starts to drop out. Our skin wrinkles. Our bones get soft. We slowly are dying. The prostate gland is the only thing in our body that actually starts to grow as we get older. When we reach the age of 40, the prostate doesn't die. It starts to grow, and it keeps on growing and growing. And that's what makes it fascinating. And that's what causes to have problems. Because if we could find out why the prostate keeps growing, then we could find the secret to long life. You know, it's very important. But
so you made an interesting point. So
yeah. So now it's important here, and I'll tell you why it's important. Because as this prostate gland gets bigger, what happens is it starts to squeeze on this tube as it gets bigger, because it gets bigger outside, inside, top and bottom. It starts to squeeze on this tube. And as it starts to squeeze on the tube, then the urine has difficulty coming out. You find the urine starts to slow down. And then as urine starts to slow down and the blockage gets more, you don't empty the bladder, so urine gets left behind. And then you start to feel you want to pee more often because the bladder is getting filled more quickly. And so you start to pee more often in the night. And then you start to pee more often in the day. And when you want to go, you got to go. And so when you see men reach around 50 and 60, they get problems with this prostate getting bigger. And that's why men get all these problems for peeing. And they reach a stage one day where the urine just cuts off and they have a blockage or stoppage of urine. And so more than half of the men complain of these symptoms. But they are the same symptoms that can happen if you had a prostate cancer. Because sometimes the prostate becomes big, not just it becomes big, what we call a benign growth, but it becomes big because it has a cancer in it. And I'm glad the women's on this program, because when the cancer starts, it's very similar to how a woman's breast cancer starts. It starts off very small, so small that you can't feel it. And so we don't want to wait till the woman can feel a lump. We tell them, get a mammogram so we can pick up this lump before you can feel it, because we know that it's early and we can get rid of it. So let us show you what happens as we blow this up. Here is the first start of a cancer. This is the first stage, a very small, in fact, it has to be about the size of a pigeon pea before the doctor can feel it. So in the first stage, it's not big enough for the doctor to feel it. And so this is, we call it stage 1, and it doesn't pain. So like a breast lump, it doesn't pain. It's very small when it starts. So you wouldn't know it's there. The only thing can pick it up is what we call the PSA, or prostate specific antigen. We talk a little bit about later, but basically it's like the mammogram. Now, if the man isn't going very often to the doctor to get checked out every year, then that little thing gets bigger. Now it's in the second stage. Now, when it's in that second stage now, he still can't feel it because it doesn't pain. He wouldn't know he's peeing as he normally pees. The passage is open. Now the doctor can feel it in the second stage. And of course, his blood test would be up. But most men, they feeling fine. They're not coming to see the doctor until you reach the third stage. Now the passage becomes blocked. Now he has problems peeing. Now he might see some blood in the urine. Now it's easy for the doctor to see. Now at this stage, my God, now this is when they come. You see what I mean? It's late. And that's why they come late. So you need to understand why and what happens and what this prostate is about, because then you reach a fourth stage where it breaks off and spreads everywhere. And then you can't cure him anymore. Or you can talk about how do I control this disease to see how long we can keep you alive before it ultimately takes over. So I wanted to say, when you say, what is this about? I wanted to take a few moments to talk about what the prostate gland is, why we get these problems with the prostate gland, why it's important to get regular checkup, why it's important to know what it is you're going to get your checkup for, because at the end of the day, if you are aware of that, hopefully you'll have a greater interest that you need to be concerned about your prostate health.
Thank you. Thank you for that, Dr. Roberts. No, that's very, very interesting. So you're saying that by the time men actually come into care, then it's a little bit too late.
That's right.
Most of it. So the question now is, how do we try to capture it, to try to get persons into care from stage 1 or stage 2? Because that's the point in which it can be treated effectively. No, you're saying that at that point, it is very hard for the doctor to use a DRE.
That's right.
So, and also that no doctor is going to routinely do a PSA at that point. So how do we intervene on stage 1, stage 2 before it gets too late? That is the question, because if we recognize that most men do not want to do a DRE examination, right? And it's not, and PSA is not routinely offered as a first line for diagnosis. How do we transition from that fear factor into something more actionable that we can present to men and say, you don't necessarily need to be, you don't necessarily need to have the DRE done, but we can still identify the cancer in your body. How do we get that messaging out and get more men in?
Okay, good. I'm going to start right at the top. And what we are talking about is something called policy. Policy. How are we going to establish some rules or some guidelines or some laws to say, this is what we should be doing to better our health? Now, we in a healthcare system, and you know that saying that says, pay me now or pay me later. So I am the government. We in a healthcare system where in our Caribbean islands, most of us, we under the British system. So predominantly, the average person visits or attends the public clinics. Most patients can't afford their own care or just a certain level of care. And the government has a responsibility to be the provider of care. And in most instances, it would at least be the last to provide of care. And so the government says, listen, I'm looking at what's wrong with my people. What are they dying from? What about men? What about women? So the government says, my God, they're dying from prostate cancer. And they're coming when they advance disease. So what do? We're going to say, can we pick it up early? Yes, we now have a test that came about in the 1990s called the prostate-specific antigen, which they say is only this chemical in the blood is only made by the prostate gland. And what it shows is when that level is up above a certain, at a certain amount, it means that that might be the sign of prostate cancer in the beginning. So why don't we institute a policy whereby we encourage the doctors to ask the patients, we encourage the patients to come forward and say, I need to have my annual test for my PSA with my PSA for my prostate to pick up this deadly disease that can happen. And we know the result. This is called screening. Okay, so we know the importance of screening, and one of the best examples of the outcomes of screening is what we see in the pap test for women who have cervical cancer. Before the 50s, the #1 leading cause of death in women from cancers of the reproductive tract was women dying from cervical cancer. #1 disease throughout the world. And then they realized they had this little simple test called a pap test where they could test a little bit of cells inside the vagina. And 15 to 20 years later, cervical cancer became a totally preventable disease. No woman should be dying from cervical cancer today if they adhere to the guidelines or the protocol or the policies that you want to call it, where they get their pap test done every year or every 2 years as recommended. Well, let's fast forward to the prostate gland. When these PSA blood tests became available in the developed countries, and they went out and they said, listen, we got encouragement, come forward, get your blood test along with getting your prostate exam. We need to tour them. And if you do that, we think that we can reduce the likelihood of you getting prostate cancer, at least the deadly prostate cancer, and dying from it. And so what did we see? Within 10 to 15 years, that in those developed countries, instead of men presenting with advanced prostate cancer, because in those countries too, for every 10 men who came with prostate cancer, 8 out of 10 came with advanced disease. What they found was those men who came forward and got their PSAs in their annual rectal exam, that 15 years later, they found that they now changed totally around. For every 10 men who came, now 8 out of 10 came with early disease. Totally turn around. And what did we find in the developed countries where we didn't institute those policies, where we didn't make it a formal part of the government system, where we didn't go forward and encourage the doctors and have the public health programs like we do now to make awareness, sensitize them? It's as if the PSA never existed because the men don't come forward. So we are still far behind, like 20 years ago, where 80% of them presenting with advanced disease. So the message is clear. We need to have a one voice, a universal voice, where the government has to direct the show, or the insurance companies have to direct the show and say, this is the standard of care because we can better the health. And that becomes very important because at the end of the day, we carry the burden of disease. We spend a lot of money treating men with advanced disease. We have a lot of suffering from the men. We have a lot of suffering in their families from conditions that which we could have prevented. So we've got to get the message out and say to the men, listen, you got to change your attitude towards this disease.
So essentially, you're saying that the messaging should really focus on the PSA screening.
Well, there are two ways to look at it. And I want to stop you now. Now, the PSA screening has become very, very good and very sensitive. It can pick up prostate cancer. In fact, it is so good, it can pick up prostate cancer even when the levels of the PSA is normal. So there's a big issue about that. But it's much, much more sensitive. The problem with the PSA is that it's not only capable of picking up prostate cancer, but quite a lot of other things unrelated to cancer can cause the PSA to be up. Now, so therefore, the PSA isn't all in all. When the doctor says your PSA is up, it doesn't mean that you have cancer. It means that you need to be checked out further. Because remember in the beginning, I talked about the fact that over the age of 40, the prostate starts to grow in all men. A bigger prostate makes more PSA. So the most common cause of your PSA going up in the beginning is having a bigger prostate.
Yeah.
You see what I mean?
Yeah.
Second thing, after when you have sex and you ejaculate, it causes your PSA to go up. And it takes about 3 days to come back down. So you got to tell the men when you do your PSA, you should have sex for about 3 days. And then you have, if there's even evidence to show if the doctor examines the prostate too vigorously, or if you had any instruments going up the prostate, up into the bladder, like a Foley's caster or any kind of procedure,
That would
could
affect
be
it.
a
Yeah.
syndrome.
That would
If
affect
you
it.
have, if you have any infection in the prostate or in the urine system, and you can have infection in the prostate in which has nothing to do with sexually transmitted disease. It's the same bugs around the skin area below that can get inside, up in the penis, get into the prostate. And in fact, that type of infection in the prostate is a type where you might not feel anything. And so we've got quite a number of things that can be recognized that can cause the PSA to be up. That has nothing to do with prostate cancer.
But,
so it just alerts us that's what we have to do. Now, on the other side of the coin, when you look, so you can't just say, oh, you mean only the PSA? That is where the digital rectal exam becomes important.
Okay.
Because on one end of the spectrum, it's not a good test to some extent. Of course, the men don't like it. But there are a lot of other things. You feel something change in the prostate. The prostate has a different consistency. You might feel some little lumps and bumps. It feels very hard. Sometimes it feels just like concrete compared to how a soft prostate might feel, almost like just a pillow, you know, that's a little spongy. So it can feel very different when it's a cancer. And but by the time you feel that,
it's advanced. Okay,
it's
advanced.
Right? So, but we also know that in up to 15% of men with a normal PSA, the prostate can be quite overtly cancerous. So the PSA isn't all in all. So the evidence is clear is that if you do both the digital exam and the prostate PSA is the best combination. But the point I try to get the men to accept is this, that having a rectal exam or examining your anal passage, it's not only about prostate cancer. There are many diseases that can happen around the anus. You have diseases of the skin. You have hemorrhoids. You have cancer of the anus. You have cancer of the rectum. You can have men come with bleeding. So there are quite a number of diseases around it. We don't normally look at our backside. We don't see what's happening there. As a part of your annual examination, the doctor should examine those areas to see if it's normal and it's healthy. So I like to say that the prostate is just a part of the routine examination you should do when you're examining that area, just like all openings in the body should be examined. The doctor
you mentioned that this should be a part of your routine medical.
It should be a part of your.
So how frequently do you advise persons to get these screening done?
And it's recommended that you should do it every year.
At least
when you reach over the age, now that becomes debatable. When do you start? So in North America, they would say in European countries, they would say you start at the age of 50. But it's very clear that men of Black ancestry or men of African descent, it's in our genes. We are more likely to have prostate cancer than white men. The data in the US is so clear that when they plot white men against Black men, that Black men are 2 to 3 times more likely to have prostate cancer and to develop it at an early age and to have a more aggressive type. And more importantly, they are 2 to 3 times, up to 4 times more likely to die from the prostate cancer. And so we say that we should start, some say 45. I believe in our population, we should start from 40.
40. Okay.
At least when you're in your 40, you should have your first examination of your prostate and your blood test, especially if you have someone in your family. Because if your daddy or your brother or your uncle, someone that close to you, your likelihood of prostate cancer is like 2 times as much.
So yes, we understand the need for screening early. What about those persons who you catch the disease at maybe stage 3, stage 4? What treatment is available for them, and what's the outlook in terms of, I guess, their life expectancy at that point? Because you mentioned that it's one of the most aggressive cancers we've been seeing, right? how well do we understand the treatment options, and how well do we, what message can you say to these persons who come into your office? It's already late, but what is their outlook? Is it a case where is it too late for them, or what options are available in terms of treatment, and how well are they right now?
All right. Now let me just take a little step back for a minute. Then I'm going to answer your question a little indirectly. The other fascinating thing about prostate cancer is that we have found that there are quite a variety of prostate cancer in terms of those that are extremely aggressive, that will take you out in a year to 2 years. And there are those that are literally just likely or non-aggressive. In other words, they grow so slowly, they might never affect you for about 10 or 15, 20 years. And so the first thing you like to know is, do I have the more aggressive type, or do I have the more indolent or very less aggressive type? That's very important. Okay. And so when we look at prostate cancer, then what we say is there are basically two types. There's the prostate cancer, where we find disease at an early stage and it's confined to the prostate. There's no evidence to show that is outside the prostate when we do all our testing. And then there's the other type where it's already outside the prostate. It's advanced. So let me address that part first that you are talking about.
Yes.
So when you are outside the prostate, as I had mentioned it earlier, you cannot cure this disease anymore, but you can control it. And I like to say there are many things, many diseases that we can't cure, but we can control. We see it in this whole program. You talk about high blood pressure, you talk about diabetes. We can't cure them, but we control them, and we control them for life. And that's how I like to think of prostate cancer, like many other cancers. We might not be able to cure, but we can control and give you a full life. And hopefully also where your quality of life is worthwhile. So the interesting thing about this advanced prostate cancer is that the principle is that the male hormone, testosterone, that's made by the testicle, it seems to act like a fuel that makes the cancer grow. And so the key is that you have to put a stop on the testicle. You have to stop the testicle from making the testosterone. And if you do that, it's as if you're taking the fuel away from the cancer, and the cancer cells begin to die. And no matter where the cancer cells are in the body, they begin to die. And you know you're effective when you stop the production of testosterone, because your PSA level drops significantly. In fact, it might sometimes drop to 0.
Okay.
And so so that is the first stage that we do. We treat men with advanced prostate cancer with what we call hormone treatment, meaning you have to stop the production of the male hormone made by the testicle, that is testosterone. If you take that away, then you can control the cancer. Now, here is the problem with that. It's very effective, but this is a very smart cancer. After about 2 to 3 years, the cancer starts to make its own testosterone.
Interesting.
Okay? And so now we have to find a new medication which will stop the testosterone production again by the cancer cells. And so we have what is called second-line treatment. And that works for a while. And then the cancer makes its own testosterone again. And so we have to find a third line and then a fourth line. So we are at the stage over the last 4 to 5 years, we now have a series of new medications for treating advanced prostate cancer. And we go from second line to third line to fourth line. And it's being very effective. For the first time now, today, we are talking about looking at advanced prostate cancer almost like HIV disease, like AIDS, where in the 80s, if you had AIDS, you died. Whereas, but today, if you can afford the newer line of medications for prostate cancer, you can live it's like a chronic disease.
Normal.
You can live for like 10, 15, maybe more years or more. But the problem is, those medications are expensive. You're talking some of them $3,000, $4,000 US a month.
Wow.
So you can't afford them.
Can't afford those.
Especially in our developing country. So we have to talk about early detection.
And
Gotta talk
that's where the
about
focus has been
That's right.
on prevention and early detection.
That's right. Now,
Mhm.
that's right. So now when we talk about, that's a way of looking at advanced prostate cancer, and we've now even found that we have chemotherapy, that, you know, that bad medication, that poison they talk about. For a long time, it had no effect on prostate cancer. But now we have found some new chemotherapy, which when we add to the hormone therapy in the beginning, it takes a longer time for the prostate cancer to evolve to produce new testosterone. So we're looking at some very nice new
Novel
medications
treatment, yeah.
and combining them and being very effective, but we got serious problems with the cost of them. And of course, some of the side effects that happen. So a pound of prevention, an ounce of prevention is worth a pound of cure.
Pound of cure, which is true for this.
Absolutely.
I mean, it's true for every disease.
Yeah, absolutely. Now, if you are fortunate, and that shouldn't be fortunate, it should become the standard where we pick the disease up at an early stage. Now, here's the other good thing about it. Now you know that if it's confined to the prostate, then it's possible to remove the entire prostate. If you move the entire prostate, you got rid of the cancer.
But
now, that's, you know, I always tell people that God put the prostate where it never was supposed to come out. See, it's kind of wedged down.
You can see it on the diagram.
That's right. It's on the diagram. So right behind it is the rectum. Right on top of it is the bladder. Right in front of it, there's a big bone, the pubic bone, so it's hard to get with. And then underneath is the valve that keeps that prevents you from leaking. And then you also have the nerves that run along the prostate that goes into the penis to give you an erection. So the problem you have when you get into that area to remove the prostate, you could damage the rectum, you could damage the bladder, you could damage the valve, you could damage those nerves. So, and then you still mightn't get out all the cancer. So you're
actually at stage 4 when it has gone.
No. I'm talking about the early disease.
Oh, the early. Okay.
You see what I mean? You think you've gotten it all because the evidence shows, but only when you take it out and you look under the microscope, you find goodness a little bit gone away. Okay, so when you do this surgery, there's a very high. In some studies, up to half of the men or more have a problems where they don't get an erection again. We have to treat that. You have up to 20% or more of the men can't control their urine and they have to wear pads. That's miserable. And then there's some cases where they didn't get all the cancer, so they need additional treatment.
It again.
So despite the fact that we have new techniques for taking it out, like doing the robot or doing laparoscopy, they all still have these major concerns. So we look for an alternative. And one of the alternatives is radiation. Radiation works very well. Just as good as almost, there's some who say surgery works a little better, but there's evidence to show that radiation is getting a little better. And there are new techniques. You don't get cut. You don't have to worry about bleeding, but radiation too has its problem. Okay. And then, of course, we got some new procedures where we can, what we call heat up the prostate. That's a very new fancy term where it's like you put the prostate in a microwave oven. It's called high intensity focused ultrasound. And you heat up the prostate and get rid of cancer cells. Or reverse, you put in these probes inside the prostate and you freeze it. It's called cryosurgery. And that kills it. So we can get rid of it.
So there are options.
What I want to tell you now, going back to something I had earlier, was that if you can identify when you look at the cells under the microscope, and especially also depending on some of the genetics that we have, you can see, my goodness, this is the slow growing cancer. It might take 5, 10, 15 years to show itself. So maybe we don't have to do anything at all. Maybe we just need to keep an eye on it.
That's what, yeah.
So we can keep a close watch on it. So we say we're going to do surveillance and we're going to be very active. So one of the new tests coming out now, the new treatment, is what we call active surveillance. So therefore, you have men. So rather than worry about having the surgery and the problems, or the radiation and the problem, and all the expenses, we say, listen, we've seen your type. You're a good type. We're gonna watch you for a while. Every year, if you get every 3-4 months, you get your blood test. We're gonna do some special X-rays at a year to 2 years. Make sure there's no evidence of no spread. You might find 10 years down the line, more than half of the men never had to do anything. They're back to normal life, good quality of life. So the options
they're there. They're out there.
Out there.
They're out there. I don't know if we have any questions from, I'm checking the chat. I don't see any questions right now. If you have any questions for Dr. Roberts, you can share in the chat. Just let me know what you think about discussion so far. But right now, it sounds as if, Dr. Roberts, that yes, we have been focusing on prevention. We've been focusing on early screening, and there are options there for treatment. What would you say if you had a chance to speak to all men right now? What would you say to them in terms of prostate cancer is real? It's very, very, very dangerous. It's very prevalent in our population, especially among Black men. What would you say to them right now?
What I would like to say to them is this. You know, when you are, as you get a little older, when you start to reach in your 60s, you know, life begins at 60. You finish paying the mortgage. Listen, you finish paying your mortgage. Your kids have finished school, so you don't have to pay for them to go to school anymore. In fact, you got grandkids now. You might be helping with the grandkids' school fees. So your kids are independent. So now you can enjoy a little bit of what you have. You can even do a little travel, you know. So you want to know, you just retired from your job. So you want to have time for yourself. Now, the last thing you want to do is get sick with something that you could have prevented
years
10 years
ago.
It's the best time of your life. And look what you do. You spend up all your money. Okay. I remember one of the saddest cases that I ever had was a pilot. He was getting his regular checkup. He went to his doctor. His doctor said, listen, your blood test is up a little bit. Can you go see Dr. Roberts? He came to see me. I examined. He felt perfectly normal. And I said, listen, we're going to keep a close eye on this. I'm put you on some medication. I want you to come back and see me in about 3 to 6 months. I want to check that blood test again. He never came back. The next thing I saw him 3 years later, he came to me. His doctor sent him back and he said, oh my goodness. He says, Doc, the doctor said I came to see you. I came to say hello. I just letting you know I'm about to retire now. I've saved some money and my wife and I, we going on a world cruise.
Wow.
In 2 months. We going on a world cruise. And when I examined and I put my finger in there, I said, oh my goodness.
No cruise.
This trouble. And I diagnosed that he had advanced prostate cancer. The key here was that at this point, he had no symptoms. He was feeling well.
Wow.
And the most important symptom of a man with prostate cancer is no symptom at all. It is when you are feeling well, you want to get checked. Okay? I diagnosed him with prostate cancer. And all the money he had saved to go on his trip, he spent trying to save his life. And 9 months later, he was dead for advanced prostate cancer.
Wow.
From a condition which he could have treated quite earlier on.
20 years ago.
That's right.
Wow. So we have a question, Dr. Roberts. In terms of this, the amount of specialists that we have here in the Caribbean, do you think there are enough so we can actually do proper screening?
Well, yes and no. I just want to take 1 second to differentiate the difference between what we call screening and early diagnosis. Screening in healthcare policy has a very specific definition. It is when you take a healthy population, so people who are quite well and healthy, but they are at risk for a certain disease that has a heavy burden on the society, that therefore, if you can pick it up early and you can treat it, down the line, you will show that you have decreased mortality. So in other words, you are less likely to die.
Mm-hmm.
So it is something where we, the healthcare providers, go out to the healthy population and we do these tests, encourage them, come get the test. You're healthy. That's right. This is a time check. That's totally different from early detection, where the individual is quite aware of his health condition. And so they take themselves to the doctor at every year or so, so that they can get checkup if something is there to pick it up early. And so what we are looking at is that when we talk about screening, that is a government directed policy. So the government therefore has to lead the charge. And if education and awareness is what we need to have, and when you do that, you need to have the resources, because you got to have the people out there who are going to make sure that they are available and have the resources to go out to you and make sure you come and have your population-based screening and so forth. Now, in that particular instance, we can do that. You do not need a specialist. All doctors are trained, general practitioners, family medicine. They're all trained in how to do a proper examination of the prostate and how to do a blood test. So we've got enough on board. You got enough on board.
So Dr. Roberts, I know we don't have a lot of time. Oh, you want to continue? I'm sorry.
Yeah. Now, when it comes to treating, now we have, we don't have enough specialists to do that training. I mean, to do the treatment.
Yes, that was my question. That was my question.
But we're building it up now. We got over the last 10, 15 years, I've been very proud of the university and the amount of urologists that have come out. And you will see almost in every area in Jamaica now, you probably have access to a urologist. And we're seeing that happening in all the other English-speaking territories. So we are behind, but we're working on it.
Okay, so we're working on it. So when we start to increase screening for prostate cancer, we should also have enough urologists out there to be able to handle the influx. And that is if we get the men to actually start going in and doing these annual, you say, screenings. Because there's always a challenge. Yes, we may have a lot of specialists out there. We might be also putting the message out there to get persons to go get their tests done. But at the same time, we don't get a lot of uptake from the messaging, right? So a lot of moving parts need to happen so we can actually reduce the prevalence of prostate cancer. I don't see any more questions in the chat. So thanks again, Doctor. It was a very interesting discussion. I can say for myself, I've learned quite a bit. I mean, I'm not at the age for getting screening as well. I just put that out there. But definitely as soon as I'll get it done. I don't know if we have if Prof. Marshall wants to say, give any closing remarks. We normally go for an hour. So thank you very much, Dr. Roberts. It was great having you for this session.
Always. This is I like to address my man. There's one final message I want to have.
Yes,
and because I'm a part of this program, that at the end of the day, to realize, I'm going back to that slide that you originally showed, that while prostate cancer is a major cause of death, at the top of that slide was heart disease and hypertension and diabetes. And the key thing here is that what is good for the heart is good for the prostate. So the men who are it is shown very clearly, those men who are physically active, those men who are less obese, those men who have a better nutritional status, and in other words, you lean more towards a vegetarian diet than a meat-based diet, they've shown clearly they are more likely to have less prostate cancer. So those same chronic diseases and the underlying factors that we see in these metabolic conditions we're talking about also stands for prostate cancer. So we have to look at the whole man. We have to take this holistic approach. It's not just the prostate, but it's the whole part. We are part of this greater being.
Yeah. Very true. So I'll hand over to Prof. Marshall to give closing remarks.
Yes, well, I don't have many. So actually, I really enjoyed this session.
Yeah.
Not just because I didn't have to moderate,
Yeah.
but also think that the way in which it was presented was really excellent, quite clear. And I mean, I feel like I would almost go to the Bahamas to try and develop prostate cancer. So try not to retire too soon.
That's
But I
true.
mean, it really was a very good discussion, thorough, and I think a lot of the messages that really want people to be aware of came through quite clearly
Mhm.
in this presentation. So I really want to thank you again, Dr. Roberts, for taking the time to join us, and also Bill for actually hosting. I have to congratulate him because he did a very good job. So we'd like to give it to him more often. So kudos to all presenters.
My final note, I just want to say one thing before I close. I want to say thanks for the women who were there, because they, when we have our community clinics, the women bring the men. Yeah, the women bring the men. Okay, so I'm happy to see that they won the program. So you make sure, take your man and make sure he's straight.
Yeah, that's true.
Yes, and I mean, I think so, and that's it. And I just want to thank the audience for joining us once again for the live talk. We look forward to seeing you again next month, the last Thursday of the month, with more cancer. But I think people will be ready for it after this. They'll be fired up.
All right. Thanks, Prof. Marshall. All right. So on that note, we will end. So see you guys again the last Thursday in October. All right. So thanks, everybody.
Thank you. Good night.
All right.